Bismillahirrahmanirrahim. This video will describe the infarction, and these are the references for this video. By the end of this video, you will find out the answer to this clinical problem, in which a 74-year-old woman is brought to the emergency department after developing left-sided paralysis for 1 hour. On further evaluation, left-sided sensory and motor paralysis, left-sided hyperreflexia, left-sided Babinski's reflex, and bilateral symmetrical loss of vision in half of her visual field was seen. She has a history of atherosclerosis. The term infarction is derived from a Latin word which is infarctus, and it means stubbed into. Infarction is development of coagulative necrosis in an area distal to the occlusion of an artery, while the infarct is a localized area of ischemic necrosis caused by the occlusion of either the arterial blood supply or the venous drainage. There are many areas in the body where this infarct can occur, such as brain, retina, lung, heart, spleen, liver, small bowel, kidney, and lower extremity. The stenosis, which is the narrowing, is not usually associated with infarct. In fact, it is associated with vacuolization. If it is in the heart, it is associated with vacuolization of the cardiac myocyte, atrophy, loss of muscle cell myofibril, and interstitial fibrosis. The causes of the infarct can be stratified as common, less common, and uncommon causes. The common causes are arterial thrombosis and arterial embolism, while less common causes are local vasospasm, hemorrhage into an atheromatous plaque, extrinsic vessel compression such as occurs in tumors, or the uncommon causes are torsion of a vessel such as happens in testicular torsion or volvulus, traumatic vascular rupture, and vascular compromise by edema such as occur in anterior compartment syndrome or by entrapment in an hernial sac. Although venous thrombosis can also cause infarction, but it is more associated with congestion, which results in opening of alternate channel and subsequent vascular outflow, which improve arterial flow. Hence, the infarct associated with venous congestion are only seen in organs having a single efferent vein, such as in testes or ovary. We can also classify the causes into two major categories: arterial causes and venous causes. The arterial causes can be by the occlusion of the lumen, such as thrombus or embolus, causes in the wall such as local vasospasm, hemorrhage into atheromatous plaque, or thromboangiitis obliterans, or can be pressure by a tumor from outside. The venous causes again can be due to occlusion of the lumen, and thrombus and embolus are responsible for this, and the extrinsic vessel compression by the tumor, torsion of a vessel, or strangulated hernia. The factors that influence the development of an infarct can be nature of the vascular supply, and the vascular supply can be dual or parallel blood supply, or it can be end arterial. When there is dual or parallel blood supply, the infarct is less likely to develop, such as in lung, liver, hand, and forearm, while in organs such as in kidney and in spleen, when there is end arterial blood supply, which have little or no collateral, it frequently develops infarct. Rate of occlusion is also another important factor. If there is slow occlusion, it is less likely to produce infarct, because there is alternate arrangement of the perfusion which develops simultaneously. Then the vulnerability of the tissue to the hypoxia is another important factor. The neuron undergo necrosis within 3 to 4 minutes of the occlusion of blood supply, while heart muscle they sustain this for 20 to 30 minutes. Then oxygen content of the blood is important. If there is partial obstruction, and this partial obstruction is in the normal individual, it may not produce any effect, but in anemic person it may produce infarction. The infarct can be classified by various ways, according to color, presence or absence of infection, or according to age of the infarct. According to the color, the infarct can be divided as white, pale or anemic infarct, or red and hemorrhagic infarct. While with the presence of or absence of the infection, they can be septic and bland, and on the basis of age of the infarct, they can be recent or old or healed. So the appearance of an infarct depends on the location and age. When there is an arterial occlusion, the supplied area swells up and becomes deep red, which on microscopy shows there is vascular dilation, congestion and interstitial hemorrhage. And with these changes, the type distinguished on the gross examination. When it is pale infarct, it is the usual characteristic of solid organs and is present in heart, kidney and spleen, and also the dry gangrene of leg comes in this pale infarct category, which is common in diabetes, some cases of diabetes. And grossly, what happens when there is initial hyperemia, and this with the initial hyperemia after 1 to 2 days passed, and it results in wedge shape, soft, sharply delineated and light yellow area with dark red borders, and these dark red borders are due to hemorrhage into the surrounding viable tissue. So microscopy for both type of the infarct, the pale one and the red one. The type of the necrosis is usually coagulative necrosis with a sparing brain, in which the type of necrosis is liquefactive necrosis. Then there is effect of duration on the microscopy, because if the death occurred within minutes of the occlusion of the artery, on light microscopy no change will be visible, because the histological change take about 4 to 12 hours to appear. Then the margin of this infarct show acute inflammation, and this inflammation appear within hours of the injury, and it becomes well defined within 1 to 2 days. The fate of the infarct, there is reparative response and the preserved margins, and in stable or labile tissue the parenchyma regenerates, and this regeneration occur at the periphery where the stromal architecture is preserved, and most infarct are ultimately replaced by scar. This white arrow is pointing to a roughly wedge-shaped infarct, pale infarct, which is based on the capsule of the spleen. And these splenic infarct are a consequence of systemic arterial embolization in patient with infective endocarditis. The mural or valvular thrombi are responsible for it, and patient presents with the left upper quadrant pain and splenic enlargement. This is another gross picture of the spleen, which is showing multiple pale wedge-shaped infarcts beneath the capsule. This is the gross picture of the spleen, which is showing that a large area of the spleen is infarcted, and it's a pale infarct, and it is sharply delineated. This is the gross picture of the heart with axial section, and showing a pale infarct of the anterior wall of the left ventricle and interventricular septum. which is distributed by left anterior descending artery. The infarct is yellow in color and the borders are hyperemic. It is almost transmural infarct. This is the infarct. Infarct is again yellow in color with hyperemic border, and this is affecting the posterior free wall of the left ventricle, which is supplied by right coronary artery. This is another photomicrograph histological picture of the myocardial infarction. This is 1 to 2 days old myocardial infarction, which is showing loss of cross striation and contraction bend in the area of the infarct, which is marked by asterisk, and the nuclei in this area are also undergone caryolipsis. The area marked with plus is showing the neutrophil are beginning to appear in this necrotic environment. This white arrow is pointing to a wedge-shaped pale renal infarct. The immediate subcortical zone is spared as it is supplied by the capsular arteries. The remaining cortex and medulla are congested. The renal infarct presents with it can be asymptomatic or present with costovertebral angle tenderness or hematuria, and it is a complication of endocarditis, rheumatic mitral stenosis with left atrial dilatation and mural thrombosis, or ischemic heart disease with ventriculomegaly or mural thrombosis. This is a microscopic picture of the kidney. On the left is the coagulative necrosis, while on the right is the normal kidney. In between these two areas, there is area of hyperemia. In the left side, the pale pink infarcted area of coagulative necrosis, in which the outline of the tubule and glomeruli is seen. So this is the gross picture of a kidney, which is showing that the infarct is replaced by a large fibrotic scar. The other variety of the infarct is the red or hemorrhagic infarct. This occurs with venous occlusion, such as happens in testicular torsion, or in loose textured or spongy tissue where blood can collect in the infarcted zone, as happens in lung, or in tissue with dual circulation that allow blood to flow from an obstructed parallel supply into a necrotic zone, as happens in lung and small intestine, or in tissue previously congested by sluggish blood or venous outflow, and when flow is re-established to a site of previous arterial occlusion and necrosis, such as happens in following angioplasty of an arterial obstruction. The red infarct can occur in lung, small intestine and brain. It can also occur in heart following reperfusion injury. It is the result of either arterial or venous occlusion, but the histology is the same as for the pale infarct. It shows coagulative necrosis. It is distinguished by bleeding into the affected area from the adjacent vessel. Morphologically, these infarct, they are sharply circumscribed, firm and darker red to purple areas, and they are infiltrated by acute inflammatory cells for several days, and these acute inflammatory cells come from the viable border, and they are also infiltrated by neutrophil and macrophage, which are responsible for the phagocytosis of the cellular debris, and there is a formation of granulation tissue, ultimately leads to formation of a scar. The cystic infarct is a term which is used to describe the cystic degeneration, which is due to liquefactive necrosis in the infarct of the brain. The septic infarction is another term when the necrotic tissue is in the infarct is treated by the bacteria, and the source of the bacterial in the lung is inhalation, while in the subacute bacterial endocarditis the emboli contains the bacteria. So after the occlusion of the middle-sized pulmonary artery, emboli are found, and only 10% of the cases of the emboli result in infarct formation. This occurs in setting where the bronchial arteries are unable to compensate for the decreased supply caused by pulmonary artery. This occurs in situation like congestive cardiac failure, where there is loss of or decreased compensation. The white arrow is pointing towards hemorrhagic infarct, and this is hemorrhagic infarct of the lung. The infarct is wedge-shaped and the base is on the pleura. It is hemorrhagic because of the continued supply from the bronchial artery after pulmonary artery blockage. Clinically, it presents with chest pain and hemoptysis. This is the gross picture of the sagittal section of the lung, which is showing that the upper part of the lower lobe is showing red infarct or hemorrhagic infarct. So the hemorrhagic infarct is roughly wedge shaped and base is on the pleura. In intestinal infarcts, the earlier changes are the necrosis of the tip of the villi in the small intestine and superficial mucosa in the large intestine. When there is more severe ischemia, it will lead to hemorrhagic necrosis of the submucosa and muscularis, but not the serosa. The mucosal infarct can be large or small. If these are small, they can heal within a few days, and if these infarcts are large and severe, they will result in formation of ulcer. As the gut epithelium has great regenerative capacity, so these ulcers may re-epithelialize, or they will result in the formation of scarring, and these scar formation, widespread scar formation, will lead to the formation of structures subsequently. If the necrosis is transmural, there is massive bleeding or perforation of the bowel, which will result in irreversible shock, sepsis, and death. This is a hemorrhagic infarct of a small bowel, and there is the dark red to grey small bowel, and compare these from that of a pink normal transverse colon, which is marked with white arrow. Ordinarily, it is difficult to infarct the small or large bowel because of the presence of extensive anastomose in blood supply. Severe compromise involving major arterial supply is necessary, such as the involvement of superior inferior mesenteric artery and mesenteric duct. The causes are diabetes mellitus, vasculitis, or cardiac failure with severe hypertension. Strangulation of hernia also give same picture. Clinically, this enteritis or hemorrhagic enteritis or ischemic enteritis, it presents with acute abdominal pain with distension. Volvulus is a term used to describe when a loop of the intestine twists around itself and the mesentery that support it, resulting in bowel obstruction. Torsion or twisting of the bowel restrict the blood supply and result in ischemia with infarction. There is a marked congestion due to venous outflow obstruction, and if this condition is diagnosed early, the twist can be corrected. In this picture, whole small bowel is ischemic and become dark red due to infarction, and this twisting area is marked by asterisk. This volvulus is rare and more often seen in adults, and it involves a small and large bowel with equal frequency. However, in younger children, it almost always involves a small intestine. The myocardial infarct can be transmural or subendocardial. When the full thickness is involved, it is termed as the transmural, and it is usually the result of the complete occlusion of the coronary artery. The subendocardial infarct is due to prolonged ischemia and through a partially occluded artery. Myocardial infarct can be pale or red depending on the extent of the reflow of the blood into the infarcted area. These are the transverse section of the ventricular myocardium, which is showing red infarct, which are caused by the reperfusion injury, which is seen in the photomicrograph A and B, while in B and C areas of healed infarct or scar are also seen. The testicular torsion is uncommon, but it is a medical emergency in which there is sudden twisting of the spermatic cord, and this cuts off the venous drainage, leading to the severe scrotal pain. This is the histological picture of torsion of testes. There is hemorrhagic infarct with no viable cells within the seminiferous tubules. Residual tubule is marked with arrow. The patient present with red swollen scrotum and acutely painful testicles without any history of trauma. And this condition can be confirmed by Doppler ultrasound, which confirms the diagnosis showing lack of blood flow. So this is a dark and enlarged ovary after torsion on its ligament. It is an uncommon condition but may occur in adults with ovarian cyst or neoplasm. This condition presents as acute appendicitis, but it can be differentiated due to presence of adnexal mass, palpable adnexal mass. The cerebral infarct may result from local ischemia or a generalized reduction of the blood flow, as happens in systemic hypotension. This can occur by the occlusion of a single vessel in the brain or occlusion of a large artery. If there is a single vessel occlusion in the brain, it will result in ischemia and necrosis in a well-defined area, and the infarct may be pale or red. It is more commonly red when it is originated by an embolus or emboli. The occlusion of the large artery produces a wide area of necrosis, and as there is liquefactive necrosis, it resolves as a large fluid-filled cavity in the brain. Hence, it is also termed as cystic infarct. This is the coronal section of the cerebral infarct in frontal lobe, showing liquefactive necrosis with beginning formation of cystic spaces, which is marked by a white arrow. This gross picture of the brain is showing the cross section of the brain in the frontal plane, which is showing a healed cystic infarct. Now the septic infarct, this cut section of the ventricles show an abscess in the left ventricle, and this abscess is formed due to seedling of the bacteria such as Staph aureus, which come here through the vegetations, and they finally end up in the abscess formation. So to summarize, we can say that there is the myocardial infarct, renal infarct, splenic infarct, infarct of the liver and lower extremities. These infarcts are pale in appearance and pulmonary infarct and intestinal infarct are hemorrhagic, while the cerebral can be pale or hemorrhagic. The myocardial infarct, cerebral infarct and intestinal infarcts are frequently fatal, but the renal are, if these renal are massive and bilateral, they can be fatal, otherwise not. The infarcts of the liver, spleen and lower extremities are not lethal. So we discussed this clinical scenario in the start of the lecture, and it's a 74-year-old woman brought to the emergency department after developing left-sided paralysis for 1 hour, and further evaluation revealed left-sided sensory and motor paralysis, left-sided hyperreflexia, left-sided Babinski's reflex, and bilateral symmetrical loss of vision in half of her visual field, and there is history of atherosclerosis. After obtaining the CT of the head and confirming that she has not got any head bleed, you immediately begin to administer thrombolytic therapy, because the cause of the infarct in this area is frequently thromboembolism. Now this quiz: a 21-year-old pregnant woman experiences abruptioplacenty at 37 weeks of gestation and develops severe vaginal bleeding that is difficult to control. 5 months later, the patient presents with profound lethargy, pallor, muscle weakness, failure of lactation and amenorrhea. Which of the following best explain the pathogenesis of pituitary insufficiency in this patient? A 60-year-old man with a history of hypertension is rushed to the emergency room with severe tearing pain of the anterior chest. His blood pressure is 80 by 50 mm of mercury. Physical examination shows pallor, diaphoresis and a murmur of aortic regurgitation. Laboratory studies and ECG show no evidence of acute MI. 4 hours later, the patient goes into cardiac arrest. An ECG revealed electromechanical dissociation. Which of the following best explains the pathogenesis of cardiac tamponade in this patient? A 63-year-old man suffers a massive stroke and expires. At autopsy, the pathologist finds a laminated thrombus adherent to the wall of the left ventricle. Which of the following is most likely cause of this autopsy finding?